Good day, everyone. My name is Robert Redwood. I go by Bobby. I'm an emergency physician and preventive medicine physician working as a physician improvement advisor for the Wisconsin Quality Center, Wisconsin Hospital Association Quality Center. And this presentation is on asymptomatic bacteriuria, an opportunity for antimicrobial stewardship. It's part of the Improvement Action Network for Antimicrobial Stewardship. Our aims and outline today is to define asymptomatic bacteriuria, to put it in the context of antimicrobial resistance and hospital-acquired infections, to talk about some of the upstream factors that lead to the unnecessary treatment of asymptomatic bacteria. We'll discuss when and when not to order a urinalysis and urine culture, discuss proper urinalysis collection technique, and when not to treat asymptomatic bacteria. And that's a pretty key point. How do we restrain ourselves? How do we not treat what doesn't need to be treated? And then we'll talk about some systems level solutions. So asymptomatic bacteriuria is a hard word to say. It actually is listed on one of the hardest words to say in the English language. And so we're going to go ahead and use the acronym ASB for the rest of this presentation, or you may hear me saying it again. But if you're giving a presentation on this to your hospital staff, you may want to practice a few times. Asymptomatic bacteriuria. It's described as an asymptomatic urinary tract infection. And some people don't even like that definition because it includes the word urinary tract infection in the definition. That describes pathologic bacteria. In ASB, there is bacteria in the bladder, make no mistake, but that bacteria is often non-pathologic, or if it's pathologic bacteria, it's expected to clear with the next void or with subsequent voids and shouldn't progress to the point of cystitis where it's actually damaging any of the structures of the bladder or the upper urinary tract. A more specific definition is an isolation of bacteria in an appropriately collected urine sample from an individual without signs or symptoms referable to a urinary infection. And that's from the Infectious Disease Society of America. A brief note on the epidemiology of ASB. 2 to 5% of healthy women will have it if you screen for ASB, which you shouldn't do. 2 to 11% of pregnant women will have it. 7 to 9% of diabetic women. And then when we get into the nursing home population and the spinal cord injury population, we're seeing rates of asymptomatic bacteriuria up to 50%. And that is largely because of limitations in functional status, inability to void as frequently as young mobile people. And finally, when you get into long-term catheter range, all catheters that are in for a long time will become colonized. And the guidelines for calling a UTI, a urinary tract infection, in a patient with a long-term catheter are pretty strict. We're talking fever, flank pain, sepsis, not change in urine color, not sediment in the Foley, not a dark urine or a foul-smelling urine. When we look at what people are actually doing in hospital and long-term care settings, up to 80% of the time, asymptomatic bacteriuria is being treated as though it were a UTI, which is wrong. And then this is kind of a special case, the catheter-associated UTI and the asymptomatic bacteriuria UTI. These are obviously separate clinical entities, and we're not going to have this lecture go deep into CAUTI, but there is a lot of overlap between CAUTI and ASB. And so just of note, every day that catheter is in place, there's a 3% increased risk of having bacteriuria. And for patients who have indwelling catheters in hospital settings, the mean time to a CAUTI, which is a true infection, a CAUTI means flank pain or fever, is 12 days. So if that catheter is in for 12 days, 50% of patients will have a UTI, a catheter-associated UTI at that point. And then obviously CAUTI increases your mean or your median ICU stay, as well as your hospital stay in general. Again, this is just a note, but the treatment for CAUTI is catheter exchange, not antibiotics. So why should we stop treating ASB? There's a lot of good reasons out there. First of all, we're losing our antibiotics, and we're losing them quickly. The map on the right there shows, or the graph on the right there shows our E. coli strains that are resistant to ciprofloxacin. And the mean number for the U.S. is 35% of E. coli strains are now resistant to Cipro. If you look at some of those higher up dots, there's health systems or communities where the rates are as high as 80% that are resistant. Hospital-acquired infections are on the rise very quickly. The C. diff rate doubled in 12 years from 1991 to 2003. And in 2003, 156 patients per 100,000 were suffering from C. diff, which is an entirely preventable problem. This is a problem that really originates from antimicrobial misuse and abuse. 1 in 8 patients who take antibiotics are going to have antibiotic-associated diarrhea. These are the hidden statistics. These are the things we don't hear about. They might not make it into our clinic settings, but they really make people miserable. They make people dehydrated. It's an example of when our drugs can make people feel worse instead of better. And then the rate for adverse drug events for antibiotic use is 0.3%, which may not sound like that much, but if you think about the tens and hundreds of thousands of antibiotics being given in the US and the world on a daily basis, those numbers become real very quickly. And antimicrobials are known for anaphylaxis as well. These are, obviously, the majority of these are going to be drug rashes, mild symptomatic presentations. However, antimicrobials are the drug class that is known for causing the most anaphylaxis. If that's not enough to convince you, we're not only losing our current drugs, we're not making new drugs either. In the 1980s, there were 16 new antibiotics. In the 90s, there were 10 new antibiotics. In the 2000s, we only made 5 new antibiotics. And in the 4 years between 2008 and 2012, 1 new antibiotic was introduced to the market. The only 5 firms, 5 of 572, that are still making antimicrobials are the major firms. But I mean, if you think about that, 1% of our pharmaceutical companies are actually have active antibacterial discovery programs. So the pipeline is weak and seems to be getting weaker, and at the same time that we're losing our drugs. So what does this mean for patients? Superbugs is a term that refers to an bacterial infection that is not treatable by any known antibiotic. So if we look at this case in Nevada, just in January of 2017, very recent, Dr. Callan noted that it was tested against everything that's available in the United States and was not effective. So we are now in the age of superbugs, and we have not had a true epidemic yet, but we're starting to see increasing frequency of case reports. And so this perfect storm of losing our antimicrobials and not producing new ones is finally coming to a head with untreatable infections. How did we get here with ASB? The urine culture was designed in 1957, and at that time, we started seeing what was actually growing in people's bladders. And there were a lot of studies out there that were actually screening asymptomatic populations to see what the, quote, UTI rates were out there. And early on, they found a pretty interesting correlation between pregnant women with ASB and pyelonephritis. And so pregnant women with ASB really do go on to develop pyelonephritis, and treatment for asymptomatic bacteria started at that time as standard of care. And so there was really just a lot of urinalyses being sent. They would come back, be regarded as a UTI even without symptoms, and treated with antimicrobials. The conceptual framework for clinicians was that asymptomatic bacteriuria was consistently harmful in all populations and warranted antimicrobial treatment. And we now know that that is quite simply wrong. And so we are fighting against a lot of dogma here. And in fact, current evidence-based literature supports only 3 times when it's okay to treat ASB. So here we go. This is your hall pass, people. If you want to treat ASB, this is when the evidence really allows it. You can treat ASB once in early pregnancy, but only treat it if you have 2 positive urine cultures. You have probably all experienced a situation where an OB or another provider treated asymptomatic bacteriuria in pregnancy with a single urinalysis or a single urine culture, and that is not evidence-based. Pre-urologic procedures are often treated for asymptomatic bacteriuria, but not treated across the board. You have to actually have ASB. And so a common practice is to treat all TERP patients without even getting a UA or a urine culture in the first place, and that is not evidence-based. And then the evidence for treating post-renal transplant patients to protect the graft is weakening. And so as the evidence grows against this practice, we may find that the times when it is okay to treat ASB drops down to 2. But the jury is not out on that. So at this point, you can treat ASB once in early pregnancy, once before urologic procedures, and once after renal transplant. So what are some clinical scenarios where ASB is commonly being treated incorrectly that we can fix? What are the low-hanging fruit for improving this, this lapse in our practice? Catheters are probably the biggest one. We are often sending urinalyses or urine culture because of foul-smelling urine, dark urine, sediment in the Foley bag, and then collection techniques, another thing on top of that. Are we actually exchanging the catheter and collecting the urine from the tube, or are we simply sending urine from the bag itself, which is almost certainly going to be colonized? This is probably shared blame between nurses, physicians, and patients themselves or patient families. And so a lot of this has to do with education and smart systems that don't allow us to send a urinalysis or urine culture without symptoms. There's a lot of convenience screening going on as well. I work in the emergency department, and I think probably every shift someone brings a urine up to me and says, "Do you want to send the urine, doc?" I didn't order the urine. I might not even know the patient yet, but it might take that patient another 2 hours to urinate. And so I'm being presented with this question right now. And if there's 10 other things on my mind, it's very tempting to say, yes, go ahead and send the urine. But I think we have to restrain ourselves and really ask ourselves, why are we sending urinalyses? And even after we send a urinalysis, should we be sending it for culture after that? Contaminated samples are frequently treated empirically or incorrectly sent for culture. And then the person gets the culture results back 3 days later and doesn't realize it was a contaminated sample. So just be sure to be mindful that if there's greater than 5 squamous epithelial cells per high-powered field, that is a contaminated culture. It is garbage, it is uninterpretable, and it should be resent, probably with a catheter, a straight cath sample. Finally, the positive UA on medical clearance exams. So again, I work in an emergency setting. There is a lot of medical protocols that have checkboxes where a urinalysis is simply on one of the checkboxes on the list. And so for me to transfer a psychiatric patient, it's pretty hard not to send a UA with the current systems that are in place, even if that patient is a healthy young person without any symptoms. And we'll talk about the way to deal with this if you're sort of forced to send a UA, or if you suffer under a protocol that has an automatic UA that really is a bad protocol. There's ways to get around treating asymptomatic bacteriuria in that situation. And then another thing that I think this is a kind of a niche situation, but it happens so frequently that it's probably worth noting, is blaming altered mental status on ASB. Obviously, this happens in all settings, in the ED and the ICU and long-term care facilities. But ASB is really an infrequent cause of altered mental status in the elderly. Hydration status is a frequent cause. Delirium due to surroundings is a frequent cause, just unfamiliar surroundings. Or delirium perhaps secondary to medications is a frequent cause. But really, and sleep interruptions in sleep habits is a frequent cause. But ASB is an infrequent cause, or true UTI is an infrequent cause. And so there's a lot of developing literature on how to deal with this. But the wisdom that's coming out is a 24-hour period of watch and wait strategy before you actually go and treat a, quote, UTI on an altered elderly patient. That is, of course, unless they have symptoms like flank pain, fever, or are progressing to sepsis. Those you would obviously treat. So how do we stop doing this? Well, I have tried to design 6 easy steps to stop treating ASB. And some of it we've gone over already, but it bears repeating. You have to recognize it's a problem. You don't know what you don't know. And if you're not aware that asymptomatic bacteria is out there and that up to 80% of it is being treated incorrectly as a UTI, then you're probably part of the problem. And so this webinar is a good first step. Talking to your colleagues, sharing this information at departmental meetings, these will go a long way in getting our health system to recognize this as a problem. Also know your high-risk populations. So when I have a patient from a long-term care facility or a patient with a chronic indwelling Foley catheter, a little bell goes off in my head that says, ding, 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 there's a high risk of asymptomatic bacteriuria here. And just having that knowledge and having that awareness is very helpful in having the confidence to look at something that looks like a UTI, look at a urine culture that appears to be a UTI, and resist the urge to reflexively treat it when the patient has no symptoms. We should not be screening for ASB, except in those three populations that I mentioned, which most of us are not dealing with those populations on a daily basis. We should really not be screening. So for the OBs in the audience, you have my permission to screen for ASB in early pregnancy. But for us emergency physicians and family practitioners and hospitalists, there's very few situations when it's appropriate to screen for ASB. We should recognize when a UA or urine culture is being sent for the wrong reasons, and then act on that. We'll talk about it. You can cancel the urinalysis, you can cancel the urine culture, or you can call a spade and recognize that it was sent incorrectly. We should diagnose UTIs with sophistication, and we'll take a few slides to really talk about the urinalysis, because I think that is an area in the medical literature that's sort of shifted. For a while, pyuria was the sexy thing to call your UTI on. Then it was leukestrase. Then it was nitrites. And this is kind of a continually evolving subject. So we'll talk about the current standard of practice and how to interpret your urinalysis correctly. And then number 6 is free text the real diagnosis. You should be empowered to write asymptomatic bacteriuria on a chart and know with confidence that you're not treating because it's the evidence. So number 1, recognize a problem. I don't know if anyone remembers this quote when Biden was talking to Obama after passing the Affordable Care Act, but this is a big deal. Up to 80% of asymptomatic bacteriuria patients are given antibiotics against guidelines. It's a big deal, and if we don't start recognizing this as a problem, we're not going to make much headway. Know your high-risk populations. This isn't a very long list. Okay, we've got 6. Indwelling catheter, spinal cord injury, urologic procedure, long-term care residents, diabetic females, pregnant females, in that order. Those are your high-risk populations. If you have bacteriuria in another population, well, maybe it's a real UTI. You should probably dig into that deeply and make sure that it's asymptomatic bacteriuria. If it's a high-risk population, have a high suspicion for ASB. Do not screen for ASB. It's as simple as that. Each and every time you send a UA, have a rock-solid reason for doing so. If you do have nurse-initiated urinalysis protocols, they really need to emphasize that you do not send a urinalysis without symptoms. There's an evolving body of literature about the dogma in the nursing world as well, that foul-smelling urine equals UTI, that dark urine equals UTI, that sediment in the Foley bag equals UTI, and we need to start busting these myths. We need to start changing the way people practice. Order sets are dangerous. So if obviously they ease the clinical flow, and in a real busy clinical care environment, they can help us move patients through the system, but it should never be at the compromise of patient safety. So if you have an order set that includes urinalysis, make sure it's an extra check. Make sure urine culture is an extra check, and then it might even be good to have some computer alerts where you actually have to click what the patient's symptoms are, or at least some educational didactics that remind people when a UA should be sent. Reflex culture orders are really going the way of the dinosaur. It's worth it to have the urine culture be an extra click, because the reflex urine culture really sets us up to screen for asymptomatic bacteriuria, which is something we shouldn't be doing. And kind of dovetailing into that, sometimes urinalysis is sent for a reason other than infection. So if you are looking for proteinuria and the UA comes back looking like a UTI, just don't send it for culture. Simple as that. That way, a provider 3 days from now isn't getting culture results and having to act on them without knowing the patient or knowing the clinical context. Obviously, in an ideal world, we'd all go back and read each other's charts and find out the exact situation. But that's not reality. When you get a urine culture result back that looks like an infection, it's very hard not to treat that, and it takes legwork. If you can avoid sending the culture in the first place, you can save your colleagues or yourself time down the road. So when is a urinalysis or urine culture being sent for the wrong reasons? We talked about these already, and we'll talk again because it bears repeating. In a Foley catheter patient, without flank pain, without fever, without signs of sepsis, do not send a UA. The urine's there. It's right there in the Foley. It's easy to send. Unless you have a good reason, don't send that UA. Foul-smelling urine is not a UTI. Dark urine is not a UTI. These are usually related to hydration status, and they don't correlate with infection, and that's very evidence-based. Screening, reflex orders, convenient samples, the incidental urinalysis that gets sent, these are the wrong reasons to send a urine culture. And so feel free to cancel those orders. Feel free to, if you don't have a way to get it off the chart, to just write, this is asymptomatic bacteriuria, not going to act on it. Now, when you do get your urinalysis back in a patient with symptoms, let's really talk about the urinalysis. Between 34% and 50% of women presenting with urinary symptoms do not have a UTI. Let's just let that soak in. Urinary symptoms do not equal UTI. Concentrated urine can cause dysuria that mimics a UTI. There's other causes of bladder spasm, etc., that can cause discomfort. Even intravaginal problems like vaginitis and vaginosis can mimic urinary symptoms. So don't be fooled into thinking all urinary symptoms equal UTI. We've got to be wise about this. Pyuria was all the rage in the 90s as the most specific and most sensitive finding on the UA to really nail that UTI diagnosis. It is a common accompaniment of ASB, and it really shouldn't influence your decision about antimicrobial therapy. So if you have a patient with no symptoms and they've got however many whites on their urinalyses, you might want to think of other causes of pyuria, but I wouldn't jump to the diagnosis of UTI if they don't have urinary symptoms. Same thing with leukocyte esterase and or nitrites. These could be present in ASB, and the clinical context absolutely matters. So again, all of these things that we rely on to diagnose our UTI are still reliable in the context of symptoms, but are not in the context of asymptomatic bacteriuria. A positive culture does not mean UTI. There are a lot of cultures being sent out there on contaminated samples. And so we are growing bacteria in our cultures that are not actually living in the bladder. Or maybe those bacteria were in the bladder, but it was transient. And that patient actually peed and cleared their bladder after the fact. And if you were to call them up on the phone now, they would no longer have symptoms. So the positive culture, on the one hand, is useful when someone's really sick or getting septic, but can really lead us astray in the asymptomatic patient. We talked a bit about UTIs in the altered elderly. There are much more common reasons for an elderly person to be altered than UTI. Reasons like medication reactions, sundowning, dehydration, or sensory impairment. If you think about that epidemiology we talked about at the beginning, 50% of nursing home residents are colonized. And so it's actually dangerous. If you blame altered mental status on a UTI only to find out later that it's actually an adverse drug event or some other clinical entity that you missed, that could be a serious miss on your part. And so treat asymptomatic bacteria in the altered elderly at your own peril. You really need fever, flank pain, or sepsis to nail down that diagnosis. And then the final myth here is once resistant, always resistant. So even when people do have a urinary tract infection, the fact that their previous UTI, or sometimes asymptomatic bacteriuria, was resistant to a certain antibiotic, say nitrofurantoin, does not actually predict that their current UTI, or asymptomatic bacteriuria, will be resistant to that organism or to that drug. And so even if someone's been resistant to one of our go-to drugs in the past, you should still try the first-line drugs. And that's a hard sell to patients. They'll say nitrofurantoin never works on me, Keflex never works on me, Bactrim never works on me. And this is an opportunity for us to educate ourselves, but also educate our patients that past performance does not dictate present. And finally, the sixth way to stop treating asymptomatic bacteriuria is to free text the real diagnoses. I know my EHR does not actually have ASB preloaded in the diagnosis list. So I have to free text it every time. Other diagnosis, asymptomatic bacteriuria. But I really think being precise is part of medical practice. And if your EHR is leading you towards an oversimplified approach, you've got to fight against that and really free text the diagnosis in. If you do this, people will recognize that you're savvy. People will be on alert for asymptomatic bacteriuria if that patient returns in the future. And you can really get someone away from a lifelong course of antibiotics every time they come into a healthcare setting. So I hesitated even putting this slide in, but let's talk a little bit about theory versus reality, because there are times in life when you are going to break guidelines and treat asymptomatic bacteriuria. And why are you going to do this? Because you have a good freaking reason, right? So you might not have total certainty that this is ASB. For example, patient feels a little twinge in their suprapubic region. I usually pee 3 times a day. Today I peed 6 times. I don't know. Could be a developing UTI. Maybe just a tiny bit of dysuria. You diagnose some bacterial vaginosis, but you're not quite sure. First, consider the watch and wait prescription. Give a paper prescription for nitrofurantoin or Bactrim. Let the patient take it home and say, if you're still having these symptoms in 24 hours, fill the script. There's no literature specific for urinalysis, but for acute otitis media, those scripts were filled only 40% of the time. So 60% of the time, those were viral acute otitis media. The symptoms went away, and the parents did not fill the prescription. If it's possible, wait for culture results, and then call the patient to reconfirm symptoms. So if you've got a soft call UTI in front of you, you might want to just give that patient some pyridium. Say, we're going to call you back in 48 hours or 72 hours. See what the culture actually grows. Is it just contaminated? Does it grow nothing? And then see how the patient's feeling. That's a way that you can still acknowledge the patient's suffering. You can still let them know that this is on your radar, but possibly avoid giving them antibiotics that they don't need. If it's not a patient you're sending home, if you're admitting a patient, consider a tincture of time. If the symptoms are mild, just resist that urge to give antibiotics. Gram-negative rods can obviously progress to symptoms quickly, but you're in a hospital setting. You've got nurses taking vital signs, that patient's being monitored. You can even tell the patient, hey, you may have a UTI. At this point, I'm not sure. There is such thing as asymptomatic bacteriuria, where it looks like a UTI but isn't one. If you start to develop symptoms on the hospital floor, let your nurse know. I think that's very kosher and very safe way to do things. If you are going to treat with nitrofurantoin, as long as people have good kidney function, then Bactrim, then a first-generation cephalosporin like Keflex. Those are the antimicrobial stewardship-friendly antibiotics to choose when you are going to treat UTI. Cipro is a no-no, and you don't have to go too big. You don't have to start with Zosyn. Kind of start small. These are very effective treatments. They have reasonably low side effect profiles. They are all generic. And this is the way we're going to save our antibiotics, is to stop using big guns for simple cystitis, or especially for ASB. And finally, if you're treating a soft call UTI, I would recommend you inform your patient of your uncertainty. Say, hey, I'm not totally positive this is a UTI. There are a lot of risks to antibiotics. 1 in 8 will get diarrhea. Some get a bad infectious diarrhea called C. diff. Some people get adverse drug events, and they're expensive. Are these risks worth it for the possible benefit of treating a UTI, or would you rather wait a few days and see if this is the real deal? I think that's a very good conversation to have, and can get you out of a lot of uncomfortable situations where patients are expecting or even demanding antibiotics. Now, how do we really deal with this in a systems way? It's not clear yet, and the citations here are single-center studies. And so this is really just starting to get on the radar, and people are trying evidence-based interventions to cut down on the treatment of ASB. But here's some ideas. Education campaigns and myth-busting is obviously the first line. That's easy, it's low cost, and we all want to know more, right? That's what you're doing today by listening to this webinar. I think that's pretty accepted. How effective is it? Probably not as effective as a system approach. And those are developing as we speak. Some people have tried uncoupling urine culture orders. In fact, I think that's even becoming the standard, I would say. I don't know what your health system is doing, but it's becoming more and more rare to see a urine culture automatically tied or reflexively tied to a urinalysis. I think we, as a health system, are seeing the value in uncoupling those two. One health system in Canada actually made the providers call labs to have urine culture results reported. So they weren't even reporting urine culture results unless the provider specifically called for them. It's kind of a little bit scary to think about all of these positive urine culture results sitting down in the lab waiting for a provider to call. But in the 3 months that they did this pilot, there were no missed urinary tract infections, and they followed up with every single patient. And so that may actually be a safe way to go. We'll see if the evidence bears out. And then, if you're in your hospital, consider writing an evidence-based protocol. There's a lot of good Foley catheter protocols out there. We are developing in Wisconsin a altered mental status protocol on what to do with the asymptomatic bacteria in the altered elderly patient. And you can get creative. You know your own health system. You know where the faults in your system are. Think about the evidence and write a protocol that makes sense. With that, we're going to end it. Not all bugs are bad bugs. It is well documented that transient bacteriuria is common even in healthy young women. And just think about that next time you see that UA that looks positive. I'm hoping this webinar triggers a little bell in your mind. Am I treating ASB, or am I dealing with a true symptomatic infection? That's a conversation that should be going on every time we come across this challenging situation. And hopefully it will become less and less challenging as awareness grows and you get some comfort calling a spade and avoiding unnecessary treatment of ASB. I hope this has been informative. I wish you all a good day. And if you have any questions whatsoever, feel free to contact me. My email is rredwood@dshealthcare.com or rredwood@wha.org. Thank you.